Welcome to the fourth lecture in the series of Trauma and Orthopaedics for medical students, aimed at covering the core topics for the medical licensing assessment. This talk is on disorders of the hand and wrist. We're going to look at some of the common elective problems and some of the common injuries to the hand and wrist. And with the elective problems, you need to be particularly aware of carpal tunnel syndrome, Dupuytren's, and know something about the finger deformities. As with all of the other lectures, we've mapped this to the MLA, and you can see this covers soft tissue injuries, a little bit of nerve injury, and some upper limb fractures. We'll start with carpal tunnel syndrome and with a definition. So this is compression of the median nerve within the carpal tunnel at the wrist due to a raised pressure, which is either increased pressure or decreased volume. So there are some risk factors that you need to be aware of, being female, being older, pregnancy, obesity, and any previous injuries. There's an association with diabetes, rheumatoid and hypothyroidism, and any occupations where you're overly using the wrist or particularly repetitive activities. You need to know a little bit about the anatomy. So it has some borders with a deep carpal arch, which forms a concave surface, which the overlying flexor retinaculum converts into a tunnel. It has 9 tendons with their associated synovial sheaths and the median nerve. The palmocutaneous branch of the median nerve is given off just before the carpal tunnel so that it doesn't go through the flexor retinaculum. So the tendons, for interest more than needing to know very much about it, you've got the flexor pollicis longus, the flexor digitorum profundus 4 tendons, and the flexor digitorum superficialis 4 tendons. So the pain is a fairly classic presentation of pain, numbness, and or paresthesia in the median nerve sensory distribution. So the palm is often spared, but it is typically the index finger, possibly the middle finger, and to an extent on the ulnar side of the thumb. Symptoms are typically worse at night, and often the patients will wake up, hang the arm over the end of the bed or give it a shake to make them settle down. Examination for carpal tunnel starts with inspection, looking really for thenar atrophy if it's chronic or severe. Palpation you usually don't find very much. There are a number of provocative tests you can do. So there's the carpal tunnel compression test, where you press the thumb over the carpal tunnel and hold it for about 30 seconds. You should get reproduction of the symptoms as you do it. There's Phelan's test, where you flex the wrist in a volar direction and you hold that for 60 seconds. That should reproduce the symptoms. And sometimes you can get a positive Tinel's if you tap over the carpal tunnel fairly firmly. You may reproduce little electric shock symptoms in the distribution of the median nerve. A lot of time the diagnosis is made by your history and your clinical examination, but nerve conduction studies or EMG can confirm exactly what is going on, the level and severity of the injury, and is very useful if you're going to consider surgery because it gives you the evidence you need to proceed with the next step in treatment. As with all conditions, the treatment can be conservative or surgical. Conservative treatment, you consider non-steroidals, possibly night splints, think about activity modification, weight loss. If there's a lot of fluid going on or hypothyroidism, you treat that. And you can try steroid injection into the carpal tunnel. If these don't work, then surgical release under local anaesthetic is a very effective way of solving the problem. If we move on to a slightly less common condition, which is ulnar tunnel syndrome. So this is compression of the ulnar nerve in Guillaume's canal on the ulnar side of the wrist. Typically this is different to carpal tunnel in that usually there's some form of ganglion cyst, which you don't see in the carpal tunnel. Again, a little bit of anatomy, but this is fairly small print. So Guillaume's canal is approximately 4 centimeters long and begins at the proximal end of the transverse carpal ligament and ends at the arch of the hypothenar muscles. And it contains the ulnar nerve, where it bifurcates into superficial and deep branches. And it's closely associated, as you can see, to the pisiform and the pisohamate ligament. So the symptoms are pain and paresthesia in the ulnar 1 to 2 digits, weakness in the intrinsics, to the ring and the small finger, and flexion or thumb adduction. This is a little bit different to the higher up lesion at the elbow, but you don't need to worry too much about that. Examination, just like the carpal tunnel, is inspection and palpation. You may see wasting of the hypothenar muscles or the interossei, particularly the first dorsal interosseous. They may have a weak grasp and a weak pinch. The more specialist test you can do is Froment's sign, as you can see in the picture. If you ask the patient to hold a piece of paper or a credit card flat with the thumb, and then you pull the credit card away, they will flex up as in the bottom picture there, because they don't have the first dorsal interosseous holding it together. And there's also the Wartenberg sign, which is abduction of the little finger, as they cannot adduct it. On investigations of these, it's slightly different, because one of the causes can be a fracture of the hook of the hamate. So it's certainly worth getting an X-ray, and if you're concerned, you can go on and get a CT scan. These often require an MRI because they're unusual, and you're looking for things like cysts or possibly even an older artery aneurysm. It's worth investigating a little bit further to try and find out what's going on, and you can go on and do a Doppler ultrasound if you really want. Nerve conduction studies are really, really useful because this will start to tell you whether it's coming from the wrist or coming from the elbow. Just as with carpal tunnel syndrome, you can treat them conservatively or surgically. The conservative treatment is exactly the same, which is non-steroidals, possibly consider an injection, activity modification, and then your operative management is surgical decompression, just like a carpal tunnel decompression. But if it's gone too far, then you may have to consider tendon transfers for the weakness. There may also be a combined problem, which is not an uncommon picture, where you've got ulnar nerve symptoms and carpal tunnel symptoms, and you have to do a combined release. We'll move on to a different condition, Dupuytren's disease. So the definition is a benign proliferative disorder, which begins as typically a painful nodule, but can progress to these cords that run up through the palm and into the fingers, and then you get contractures of the palm and the fingers. When you look at the patient, there are painless nodules, or even these bands, as you can see in the picture here, and they're typically found at the metacarpal and interphalangeal joints. There aren't really any investigations to do here because the diagnosis is fairly self-evident. The treatment options non-operative, you can watch them. Occasionally you can do what's called a needle aponeurotomy, so you can cut the little band with a needle. And if it gets too severe and the contractures are too great, you can do what's called an open fasciectomy, when you take out the fascia and the cord, and this has to be tracked up into the fingers and can be quite a complicated operation. We'll look at a few common finger deformities, just really so that you can recognize them and understand the pathology. So the first one's mallet finger. So this is caused by disruption of the terminal extensor tendon to the distal interphalangeal joint. Classically, this would be something like trying to catch a cricket ball. It lands on the finger, hyperflexes it. And what you see when you look at them is the distal phalanx rests with a little bit of flexion there, and they're unable to straighten it. So the treatment, most of the time you don't need to do many investigations, although typically you get an X-ray to see if you can see a little fracture. The treatment then goes on to be extension splinting. So you wear these little mallet finger splints for about 6 to 8 weeks, and usually that settles everything down. Occasionally there is a little bit of an extensor lag, but it's usually not a big issue. If they're very chronic injuries and the patient's struggling, or they get arthritis, then you can go on and treat these surgically. It may be possible to repair the attachment, or occasionally the joint can be fused. Trigger finger is another palmar problem, and this is where the tendon gliding is impeded. So it's typically at the level of the A1 pulley, which is in the palm, and there's a little nodule in the tendon which gets stuck as it goes under the pulley. And what the patients will describe as the finger bending and being unable to straighten it, or being unable to bend it and having to give it a push. There's often a click and a little bit of sharp discomfort which goes away. They can wake up in the morning with the finger stuck and they have to actively straighten the finger. Clinically, when you examine them, it's fairly simple. You can feel the little nodule, that indicate where it is, and you can feel it move and get stuck and trigger as you flex and extend the finger. There aren't really any investigations you can do, and the treatment can be conservative advice. A steroid injection around that pulley often works very well, and if that doesn't work, you can release the pulley with a small incision, and that settles the triggering down. Now look at a couple of deformities of the fingers. So the first one is this swan neck deformity, characterized by proximal interphalangeal joint hyperextension and then flexion of the distal and the middle interphalangeal joints. And then they have impaired function because they can't really make a full fist. Clinically, it's fairly easy to make the diagnosis, and they're often associated with conditions such as rheumatoid, and you start to lose control of the tendons. There aren't many investigations you need to do here, and you can treat them with physiotherapy, splints and surgery. Really, at your level, you need to be aware of what they are and you can recognize them, but you don't need to know much more. Almost the reverse of the swan neck is the boutonniere deformity, where you get metacarpophalangeal joint extension, proximal interphalangeal joint flexion, and distal joint extension. It comes from the French meaning buttonhole, because the central slip at the proximal interphalangeal joint fails, and this then lets everything sublux round. And again, this is quite a common rheumatoid problem. And the treatment, again, much the same, which is splinting, occasionally steroid injections, and surgery to repair the slip and correct everything if that is appropriate. We'll now look at some of the common injuries around the wrist and hand, and you need to know about the ones in purple. The other ones are really more for background information and completeness. Again, we are mapping them to the MLA, and you can see how it lines up here. Let's start with the distal radial fractures. There are three eponymous names that you need to be aware of: the Colles fracture, the Smith's fracture, and the Barton's fracture. In any injury, you need to assess the neurovascular status, because it is possible to give yourself acute carpal tunnel syndrome and occasionally possible to damage the arteries. The investigations for all of them are pretty simple in terms that you need an X-ray, an AP and a lateral X-ray. Very rarely do you need further other imaging. If you're very worried that it's gone into the joint, then that might need a CT scan. If they're displaced, they need some form of reduction, so putting everything back in the right place. And once it's in the right place, it needs to be held. And that might be with a cast, it might be specialist management with some form of surgery. So the presentation for all of them is really very similar. They tell you what's happened. They've got tenderness. If you palpate them, it hurts. And they've obviously got a very limited range of motion. I mentioned the neurovascular assessment earlier on, but you also need to check that there aren't any open injuries which will convert this from a closed fracture into an open fracture. Radiographs are all you really need, and if you do any form of reduction, please don't forget to repeat the imaging and repeat the examination afterwards. So the two most common ones are the Colles fracture and the Smith's fracture. So the Colles fracture is the most common, and this is where the distal fragment is dorsally angulated, and it's described as having this dinner fork deformity. The Smith's fracture is the injury to the volar side, so it goes the other way, and in theory you get a slightly different deformity clinically. The Barton's fracture is a little bit more complicated because this is a fracture dislocation of the radiocarpal joint, and they can either be volar or dorsal. These are really variants on the Collies and the Smiths. You don't need to be particularly aware of them. You do need to know something about the Collies and the Smiths fractures though. We'll move on to the scaphoid fractures. So these are important because of the anatomy of the scaphoid. You need to be aware of this. So anatomically, the scaphoid has three parts. There's a proximal pole, a distal pole, and the waist. And the blood supply is unique in that it comes from the radial artery, and the dorsal branch, which is the important one, enters at the distal pole and then travels backwards to the proximal pole. And when you injure these, it's possible to then damage the blood supply and you get avascular necrosis of the scaphoid. Once that happens, the bone collapses and then you get arthritis of the rest of the wrist. Therefore, we are very aware that this is a risk and we're looking out for it. So the presentation classically is tenderness in the floor of the anatomical snuff box. So this is, if you lift the thumb up in the air, you see the two tendons. The point at the base of that is the anatomical snuff box. There's pain if you can palpate the scaphoid tubercle on the dorsum of the wrist, and pain if you telescope the thumb, so you compress it. There's a set of views of the scaphoid, but quite often you can see it well on a wrist x-ray. You may see a fracture acutely, and on this x-ray it's quite hard to see on the first one on picture A. But then if you bring them back a week, 10 days later, you may see something a little bit more obvious. If you're worried about it, then a CT or an MRI may pick it up more acutely and allow you to get on with treatment more acutely. So the management of these, if they are undisplaced, can be a period and a cast, or if they're displaced or there are nursing and job reasons why it needs to be stabilized, then you can do either a percutaneous or what's called an open reduction, and you put a little screw in which compresses the fragments. So as I mentioned, the things you worry about with these if you don't get them in time are avascular necrosis, or non-union where it fails to heal, or malunion where it heals with a bit of a bend on it and that disrupts the function of the wrist. And ultimately you get this fancy thing which you really don't need to know anything about called SNAC, which is a scaphoid non-union advanced collapse, which is basically an arthritis of the wrist. We'll now look, the last topic is about tendon injuries. So a little bit of the anatomy of the flexor tendons. So you can see that the superficialis tendon divides and inserts into the middle phalanx, whereas the profundus tendon goes all the way and inserts into the distal phalanx. And there's the A1 pulley at the metacarpal head that I was talking about with trigger finger. So the injury to the flexor tendons most typically is some form of laceration, and you don't need to worry about this. You can divide it up into zones, and it is possible to predict the injuries based on the zone that you've got. So obviously in zone 1 you've only got the profundus tendon to the end, and so if you're in zone 1 it's got to be only the profundus, and in zone 2 it could be either one. But you don't need to worry about this, you just need to be aware that it is possible to predict what's going to be torn. So the presentation very simply is they'll show you a wound and they'll have an inability to flex the finger or that joint, and it may be painful and weak if you try to resist. So physical examination obviously is inspection, and if you work out the zone you can predict things. You can look at the resting posture of the hand and see how it balances, and then you can measure the passive wrist flexion and extension and the active finger flexion and extension for each digit alone, and then you can start to isolate what's going on. And then you do a neurovascular exam, as obviously it's possible to cut digital arteries at the same time. Investigations typically will get an x-ray because there may be an associated fracture or possibly even little pieces of glass in there. And then an ultrasound really to have a look at the laceration and where it is and is it complete. The treatment, as with all injuries, can be non-operative initially, with managing the wound and getting the fingers moving. Very much depends on where the injury is and how much of the tendon is damaged, or operative where you repair the tendon and then get them moving, but manage it so they're not overloading the tendon, allow it to heal. But very importantly, it's got to keep moving to keep gliding, otherwise it can get stuck. The worst case scenario is you can actually move tendons round to cover other tendons if you need to. The final tendon injury to mention is the extensor pollicis longus, which runs to the ulnar side of the thumb on the dorsum. So it is prone to rupture as it goes round Lister's tubercle, which is the little knobble on the back of the radius. And there's some friction there, particularly in conditions like rheumatoid or other inflammatory conditions, and it can rupture. Again, having a distal radial fracture with a sharp edge of bone there can also cause it to rupture. The clinical examination for these is, again, look, and you'll often see the tendon torn. You can palpate it, and if you get the patient to put the hand flat, palm down, and they try to lift the fingers and the thumb away from the table, they'll be able to do it, and you'll see the lack of that second tendon on the back of the thumb. The imaging, if there's been a fracture, then you need to make sure that you've got x-rays of the fracture. Typically an ultrasound will identify it very easily, but if there's more of an inflammatory condition going on, then you may need to get an MRI. Having a rupture of the EPL is quite disabling, so these tend to get treated surgically. If it's very acute, it may be possible to do a direct repair. If there's a bit of a gap, you can use a free tendon graft, the palmaris longus, the redundant tendon in the palm can be quite useful for that. It is possible to do a tendon transfer, so the extensor indicis for the index finger can be moved across, and ultimately you can fuse the thumb, but that's less common. That concludes this talk on wrist and hand pathology. I hope you found this useful, and please do have a look at the other lectures in the series to help you through the MLA.